So, very good morning to all of you. So, on behalf of AMS, I welcome you all for this panel discussion. First of all, I would like to thank AMS President Dr. Ravindra Sarnaik sir and AMS Secretary Dr. Nanesh Patel for giving us this opportunity.
I thank too.
Yeah. So, I am Dr. Manoj Paukar. I will be one of the moderator for this session, and this is Dr. Archana Deshpande, a pain specialist. So the topic for today's panel discussion is about acute pain management. I think every clinician in their clinical practice must have come across various kind of acute pain. There are individual various types of pain, various locations of pain. Individual specialty will have their own approaches towards the management of this pain. But we never had a panel discussion of all these multi-speciality taken into consideration so as to give a final protocol as to how do you manage those pain individually. Are there any differences? So for this, we came out with this idea of having this unique multidisciplinary approach to understand this pain. So we do have 5 eminent panelists for this today's session: a surgeon, a physician, orthopedic surgeon, anesthetist, a pain specialist, and a gynecologist. So as we all know that we do have our own 4 vital signs, but now the pain is considered as the 5th vital sign which needs to be assessed and treated, which is as important as checking the other vital signs. It is to increase their awareness, it is added as a 5th vital signs. There are so many myths, the misunderstandings about the pain management, and we need to understand how do we actually treat all this pain, because we need to take into the consideration all these 3 parameters to tackle this pain: the physical parameters, the psychological, as well as the pharmacological. So to take it into consideration, we'll start with our this panel discussion. So I will try to take this first discussion topic as to what is the importance of this acute pain management. What will happen if patient doesn't get treated for his pain? What would be the consequences this patient could suffer if we don't provide him good analgesia during this treatment? So starting with this, we'll ask to Dr. Pradeep sir. Yeah, what have you seen clinically the importance for managing this kind of pain?
Thank you.
Yeah.
Very good morning to you all. It's a very pertinent question that what is the importance of pain and why should you manage pain? Pain, as we all know, is a very unpleasant sensation, and depending on the severity of the pain, it can really make life quite a disturbing event. So the first and the foremost importance of managing pain is that it is our duty to offer comfort to the patient, if not cure. So we are duty bound in controlling pain of the patient. In addition to this, presence of pain also has several adverse consequences. Pain, as we all know, leads to multiple physiological abnormalities. It alters immune function, it alters coagulation defects. So all those things can be a consequence if pain is not managed adequately. Pain is a hypercatabolic state, pain leads to increased oxygen demand. So all these things have an adverse outcome, and to prevent these from happening, pain needs to be controlled. One important aspect of pain control is in patients who are unable to communicate, like patients who are on ventilators. In critical care, involves a lot of use of ventilators. So patients who are unable to communicate, you have to control their anxiety and agitation, which they might be suffering because of pain, and they are unable to communicate. And one thing which also is present is if inadequate control of acute pain can lead to chronic pain syndromes.
Yeah.
So in addition to all these adverse outcome, we can prevent development of chronic pain syndromes if we provide adequate analgesia to the patients.
Yeah, I think, do you see any systemic problems which aggravates if you don't control the plane, like any cardiovascular pulmonary risk which increases or generate other gastrointestinal problems?
So there are multiple adverse physiological consequences of chronic pain. It increases oxygen consumption, it increases oxygen demand, it's a great sympathetic stimulator, so it increases heart rate, it increases blood pressure. So all these changes have an adverse outcome in the physiology of the patient, especially more so in the patient who is critically ill.
Yeah. Alankar, yeah, for the patient with post-operative pain, unable to control, what problems you see in those patients?
Patient has pain, he won't cooperate in management. For example, if we want him to move, if we want him to walk, especially the kind of surgery that you and me do, we want our patients to mobilize early. The earlier the patients start walking, there are so many implications. The earlier they start walking, they have less complications like DVT, stiffness, all those things. They can do better muscle exercises, muscle strengthening, muscle control, they don't fall, so no complications like that. If they have less pain, they stay in the hospital less, the cost is reduced, so many implications. Most important, if patient does not cooperate in rehabilitation, the sense of a surgery is lost. And for little things, for example, sir said it leads to increased blood pressure. If the patient has pain, he won't sleep. If he won't sleep, he won't feel better. So I think
That is true.
management of pain control in surgery, post-surgery is pertinent.
Yeah. Nirmal, you wanted to add anything, any metabolic stress responses which could happen if the pain is not controlled?
Yeah, if you see the physiological response to pain, pain is basically an unpleasant symptom for the patient. And this leads to physiological alterations in the form of tachycardia, hypertension, sometimes respiratory depression. Maybe like we are more concerned with laparotomy patients, and patient is not able to breathe properly, the tidal volume goes down, tachypnea increases, hypoxia can ensue. So, and ultimately the patient goes in for an acute stress syndrome kind of a thing, where he is depressed and is not able to cooperate with the recovery.
Yeah, yeah. Neeta, do you have any case where you are intractable labor pain which are not able to control and patient developing any other systemic problems?
During labor, the pain severity is subjective, so we should address each and every patient's pain properly. But the choice is to be given to the patient, because we cannot have intractable pain if she has really opted for some labor analgesia. That happens only, yes, it happens when there is intractable pain and patient demands a C-section because of pain.
Yeah.
But that is because they have denied the facility of labor analgesia.
Yeah, okay. Kiran ma'am, I think these patients with acute pain will come at a later stage to you. So have you seen any physical, psychological, any impacts when you start treating these patients of having a bad experience of these acute pains previously?
Yes, at the outset, first let me congratulate the Academy for keeping a panel discussion on this such an important topic. At the same time, it is very much neglected. And as the other panelists have already said, that acute pain, it leads to chronic pain. So if it is not managed properly, then it has many sequelae. And chronic pain, actually, then it becomes very difficult to treat. So if we manage the pain post-op, that is the best thing to do for enhanced recovery and decreased hospital stay also. And we have seen many patients, like for example, after amputation, if the person is not, patient is not properly managed, then there is a phantom limb pain. So we have many patients who come with phantom limb for managing as chronic pain.
Yeah.
Thank you, madam. In continuation with this, we have seen there are many different types of pain and we need to treat them differently. Can you elaborate on that?
Okay, there are many classifications of pain, but importantly, there are, depending on the time, it is divided into acute and chronic pain. So acute pain is usually the post-surgical pain or post-traumatic pain, and it is much easier to manage with routine analgesics. And it usually subsides with the tissue healing. But if this acute pain is not managed properly, then it extends beyond 3 months. So within 3 months, it is acute pain, and more than 3 months, it is usually chronic pain. And once the chronic pain sets in, it is very difficult to manage it. Another classification is depending on the tissue which is involved. So there is nociceptive pain and neuropathic pain. So nociceptive pain is where the tissue, which type of tissue is involved. It is again divided into somatic and visceral. Somatic is coming from the skin, subcutaneous tissue, bone, muscle, joints, etc. And visceral, of course, from the viscera. Neuropathic pain, it involves the nerves. So basically there is a sensitization of the peripheral and central nervous system which leads to the chronic pain, and this is the neuropathic pain. It's very difficult to manage.
Yeah, I think, thank you. Now we'll move ahead with the third question. It's not moving. So this is for Nirmal. Now a patient is in the emergency room and you already diagnosed it as a severe biliary colic. So how will you proceed for the evaluation of this patient? Already it is diagnosed. Now how will you manage his pain? What is your first line of drugs which will prescribe for this patient?
If the patient has already a diagnosed case of a biliary colic and if he is not vomiting, then I'll prefer oral NSAID. And obviously, because usually the patients of colic have a reflex vomiting and unable to take oral, then we shift to injectables. In injectables, we start with IV paracetamol. If not relieved within about half an hour of parenteral paracetamol, I'll switch on to NSAID, preferably a diclofenac kind of a drug if it is not contraindicated.
Okay. Do you follow any step ladder patterns of the
Yeah, step ladder, slow escalation. If tolerating oral, start with oral acetaminophen or NSAID. If not, then go for IV. And still, if the patient is not getting relief, then you can maybe add opioid group of drug.
So if the patient is having severe pain, what is your protocol? Like you want to keep him in the ward or can keep in the ICU if that pain is?
Yeah, that depends on, like, if your the question is about biliary colic, if it is associated with a cholecystitis kind of a syndrome, then usually IPD admission is required. And if a patient is in frank sepsis, hypotension, then an ICU admission will be warranted.
Okay. Nowadays, even in orthopedic trauma, we can sometimes give the local blocks. If there is a femur fracture, femoral blocks. The individual blocks for pain analgesia management is nowadays also recommended in the casualty itself till the time we take him for the surgery.
For biliary colic as such, giving blocks, no. If the patient is not getting relieved of a biliary colic, then there has to be an obstructive stone either into the cystic duct or into the bile duct. And if with regular analgesia, if the patient is not responding, then a therapeutic procedure like an ERCP would be warranted rather than giving up blocks.
Okay. So what is your cutoff line to go for the next line of drugs? When do you use the?
A couple of hours, I'll observe the patient. If he's getting relief good enough, LFT is showing raised transaminases and alkaline phosphatase, and patient having TLC of more than 15,000, 16,000 and signs of sepsis are there, then a therapeutic intervention is warranted immediately.
Okay. How do you individually increase the doses of these analgesics? Like you started paracetamol 1 gram BD, then TDS. How do you assess that?
No, we start with, suppose if we're starting with IV paracetamol, 1 gram TDS is the minimum dose that should be given to the patient. If on this the patient is not having relief, then we add another group of drug rather than escalating the dose of the of that particular group.
Okay. Yeah, Dr. Pradeep, you wanted
actually,
to?
we were coming to
Giving
you.
paracetamol as a first-line drug in a patient with severe biliary colic, I don't think is a proper choice.
Yeah.
You need much more stronger analgesic than a simple analgesic.
An
paracetamol.
antispasmodic. alone.
Maybe even narcotics. Why not
Yeah.
use narcotic
not?
if it is a severe biliary colic?
That's what
So
actually.
the management, rather than having a step-ladder approach and going from a simple analgesic to NSAIDs to weaker narcotics and a stronger narcotic,
Yeah.
we should base our management based on the severity of the clinical illness.
Yeah, yeah.
The panel-
the
aim of
question
the
which
panel
I would like
discussion
to
is
ask,
that
how do
only.
you see this, I mean, do you change your drugs with the age? Like in elderly, you prefer not to?
Obviously, no, severity of illness, presence of comorbidities, the profiling the adverse outcome to the clinical context in situation, all those things need to be considered rather than going a simple step ladder approach. A horses for courses approach would be better than having a uniform approach for all patients.
Yeah. So what happens if sometimes I write for trauma 2 or 3 medication, some side effects occur,
Yeah.
and physician come and ask to stop everything. Then how do you manage that pain?
So there is no medicine which cannot be given to any any situation. There has to be a medicine. See, you must offer comfort to the patient. There is no absolute contraindication to any drug which is available in the market. That it should not be used. It cannot be used. No
Okay.
one is anaphylactic to all agents available.
Yeah.
Our next question is to Dr. Dr. Mishra sir. A 50-year-old female, known case of diabetes and hypertension with chest pain, comes to you. The ECG is normal. How do you proceed in such scenario?
You gave a simple question to Dr. Patle. You said it was diagnosed case of biliary colic. And now you are making life worse.
They
There is a
understand, sir,
bias.
they understand the physician.
So by saying normal ECG, I don't get what exactly you mean to convey.
Yeah.
Normal ECG means
Non-cardiac.
non-cardiac pain.
Yes, because
that
cardiac
is-
pain would have been easier to
But
answer.
that is never the clinical situation. A normal ECG doesn't mean a non-cardiac pain. Anyway, because this patient, as you say, is a 50-year-old female who is diabetic as well as hypertensive. So all these two things still make a cardiac pain as if very high on the list of priorities. Anyway, chest pain is a very common situation and has a long list of differential diagnoses. As a clinician, my first priority is to identify those patients who have a life-threatening disorder.
Yeah.
So if I can exclude life-threatening disorders, I am comfortable, I have time on my hand, and I can take things easily as they come by. So what are these life-threatening disorders which present with chest pain? Most important one is acute coronary syndrome. You say ECG is normal, so I would take it, I will assume that there is no evidence, so there, even by going further, investigations are not required to confirm or rule in or rule out acute coronary events.
Yeah.
If acute coronary events are ruled out, then other life-threatening disorders include pulmonary, she is a female, hypertensive diabetic risk factors, so she can have an aortic dissection. Aortic dissection again is one condition which is life-threatening, presents with chest pain. If you have to think of aortic dissection, make a point to record blood pressure and palpate all the peripheral pulsations and record blood pressure in both the arms. Pulmonary thromboembolism is one condition which can present with chest pain and have devastating consequences. So one should consider pulmonary thromboembolism, cardiac tamponade, look for raised AVP, muffled heart sounds, and low blood pressure. Then you have tension pneumothorax. The pneumothorax and tension pneumothorax can present with chest pain and have a life-threatening, and wherein tension pneumothorax is always a clinical diagnosis, and the management is to be done immediately. There is, if someone says that he would confirm a presence of tension pneumothorax by doing an X-ray, he should be failed in examination. So tension pneumothorax always is a clinical diagnosis which we must consider in any patient with chest pain and in distress. So all these are conditions wherein, which are life-threatening and present with chest pain. Think of them, rule them out by careful physical history and physical examination. Apart from this, other causes of chest pain like from the chest wall, like costochondritis, or one condition which is difficult to diagnose is herpetic neuralgia in the pre-eruptive phase. Can present with severe chest pain and have nothing on examination. You have pleuritis, you have pericarditis, you have esophageal pains, you have peptic ulcer pains, and one of the most common causes of chest pain in clinical practice is psychosomatic illnesses presenting with chest pain, especially females, anxiety, depression, somatiform disorders, all those can present with chest pain. So given in this clinical context, rule out
Yes.
life-threatening
I
disorders.
think,
What will be your choice of analgesics? Just to ask you, generally what you start with?
Again, I have said, no, depends on the clinical. If
Yeah.
I have costochondritis, I will start with an NSAID rather than an analgesic. If the patient has a psychosomatic illness, I will have to address that in addition to analgesics.
Okay.
So
I
the
think, yeah.
treatment will depend on what is the clinical context and what is my first
here we need
possibility.
multidiscipline, like from
Okay.
cardiologist ruling out cardiac, then a physician, other causes, then musculoskeletal pains, this costochondritis is a complete battery of investigation I think this patient should have. Yeah.
The next question is to Dr. Sapre. A 25-year-old primary gravida with history of preeclampsia in mild labor pains. What are the different modalities of pain relief available to you and how do you go?
This young lady, primary gravida, you have given two important things here. One is that she has preeclampsia and that she has mild labor pain. Depending upon her investigations, I would like to first know whether I'm dealing with a very severe type of eclampsia. So I'll order her platelet count, the coagulation profile. If that is okay in this lady, my choice would be to give epidural analgesia, because in all patients of preeclampsia, early initiation of neuraxial analgesia is recommended in all patients. As regards to her mild labor pains, as I've already told you that early initiation is recommended. On top of it, the perception of pain can be different. So even a simple maternal request is enough indication to start with effective analgesia.
Other than epidural, what else do you practice?
Yes, the choice, the options should be driven by patient preference. So we should be giving her all the options. For mild labor pains, we should always start with non-pharmacological therapies. There is water immersion technique, there are water blocks, then TENS. When it comes to pharmacological methods, we have systemic injections, the parenteral narcotics like fentanyl. These systemic injections like nalbuphine, butorphanol, pentazocine, tramadol are available. There are some inhalational methods also there, the Entonox and some halogenated compounds. And lastly, the gold standard, as I've already said, epidural, the neuraxial analgesia.
So depending on the patient's condition, we select, and the patient wish, we select the mode of
Definitely.
analgesia. Okay.
But I'm sure with proper counseling, we can help them to choose the best analgesia available.
Yeah. So this is next question is for Alankar. As a surgeon, even while doing a knee replacement or hip replacement, I want the patient to have the best pain-free experience throughout. So Alankar, what protocols or tricks you apply pre-operatively or even intraoperatively to give them the best experience for this surgery?
I would like to address this question in a different perspective, for example.
Okay.
Let me declare before I tell you how I control my pain, that last 500, 600 patients, I have used diclofenac maybe 5 or 6 times. So none of our patients need like extra out of the way, going out of way and giving them painkiller, in spite of all of them having written orders to give them diclofenac in case they have a face pain scale more than 6 pain. So here, when I think madam also mentioned about counseling. When I tell my patients about knee replacement surgery, before surgery I tell them to expect pain. This is in contrast to what my colleagues and all of us are doing. So we are promising them, we will be pain-free surgery, pain-free surgery. I tell them, surgery manje shalya chikitsa. Shalya manje dukhna, pain. And we are doing your chikitsa by pain. तुम्हाला I will speak in Marathi, please pardon me. तुम्हाला साधं खर्चटलं तरी तुम्हाला दुखतं ना, तुमचं इतकं मी 10-12 सेंटीमीटरचा चिरा देऊन ऑपरेशन करेल. आधी करायचं तसं मोठा चिरा देत नाही, छोट्या चिराने करतो, तरी तुमचं ऑपरेशन तर होणार आहे ना, तुम्हाला पेन राहील असं एक्सपेक्ट करा. Now they get 2 kinds of information. First information they get from surgeons, where the surgeons tell them we will do zero pain technique, zero pain technique. I have never met in last 25
Priming
years
of this patient.
any
before it.
patient who has undergone surgery and does not have pain. We will have pain. When there is epidural, they will have no pain. And then this is one extreme where they say you will have zero pain. And then when they have pain after the epidural is out or analgesics are out, they have pain and they are disappointed. And the other extreme is relatives who have been told by somebody else, here say, तुम 6 महीना पाँव पत्थर का हो जाएगा, एक कदम नहीं रख पाओगे. So they are two different spectrums. I tell them, the truth is somewhere in between. You will have some pain, but we will manage your pain so much that you will be able to walk effortlessly. You will be able to walk with support. You will be able to use toilets. You will be able to climb stairs. So when the epidural is out and their pain starts creeping in, they know already. So when I go on the rounds and ask them, काका तुम्हाला पेन आहे का ते म्हणतात डॉक्टर थोडं पेन आहे तुम्ही सांगितलं ना पेन तर होणारच आहे पेन एक्सपेक्टेड आहे सो माय पेशंट्स आर नॉट स्ट्रगलिंग सो इन ॲडिशन टू वॉट यू सेड the tricks that we are using, we use preemptive pain control. The night before surgery, they get pregabalin, so they sleep well too. The morning of surgery, they get IV paracetamol 1 gram.
Yeah.
And so the only painful sensation they have is the IV prick when they get painkiller, and then there is epidural, and then there is spinal, they have no pain. During the surgery, we do a lot of infiltration with a cocktail. If you allow me, we will discuss this. So a lot of drugs are there. Everything under the sun, we give them. And after surgery, they are pain-free for 48 hours because of epidural, and even after surgery. And then we also use a lot of ice packs. Counseling, multimodal analgesia, preemptive analgesia, ice packs, cold fermentation, all these things. And most of my patients, they are okay. And I have never claimed to my patients, so managing patient expectations. I tell them, expect some pain. So what happens if you tell them that you will have no pain and they have little pain, they are unhappy. But if you tell them before surgery, expect some pain, and they feel, sir, आपने तो बोला pain होगा, pain तो नहीं हुआ. They are happy.
Correct, yeah.
Thank you.
In
I would like to
continuation
add,
with that,
I
preemptive.
This is fine,
Yeah,
yeah.
no, I just want to add a little bit that epidural has been and always will be the gold standard.
Yes.
So I think that is a wonderful procedure, and no need to, all panelists
of
agree
course.
with that.
Without that regional anesthesia, they won't be able to operate itself. So that is no doubt. And in continuation with this previous question, I would like Dr. Kiran Vyavhare to elaborate on preemptive. Is it, and when do you use it? In which kind of surgeries do you use it?
Okay, preemptive analgesia, as the name suggests, it is introduction of the analgesia before the onset or before the surgical stimulus or the noxious stimulus. That this is attempted in order to prevent the sensitization of the nervous system. The peripheral as well as the central nervous system gets sensitized because of the pain. If this preemptive analgesia is followed, what you can do is you can manage the patient much better way. And like Dr. Alankar has said, preemptive analgesia we are also using before the surgery. A night prior surgery, the pregabalin is a very good drug which can be used. And of course 1 gram of paracetamol. And for suppose like many times it happens that in the wards you cannot manage the pain because you are many times the instructions are not followed. So what usually we do is after the induction of anesthesia and till the surgical incision, there is some time that is available where there is draping and cleaning, draping, everything. So that time at the onset we give 1 gram paracetamol and I insert Zonac suppository if it is not contraindicated. So NSAID has been also the gold standard if it is used judiciously and in patients without any contraindications.
Yes.
So the drugs
That's
routine
very
that we follow is again paracetamol, NSAIDs, opioids of course, and specific, many times we put catheters also just for analgesia.
Yes. And a night before some benzodiazepine also.
Yeah,
and
benzodiazepine,
antiemetic. Yeah.
antihistaminics also.
And
Nirmal, you
there
wanted
is
to add
something, Maxelf, and that is a very well-known cocktail solutions like magnesium sulfate or lignocaine can be added in that paracetamol drip.
Yes,
Yeah, Dr. Patel.
Maxelf, it acts by the NMDA
Yeah.
antagonism.
Right.
So that is also a very good drug.
But it depends on the choice of the anesthetist and the surgeon
Yes,
which cocktail
definitely.
to be given to the... Yeah, you wanted to
In
add.
addition to what Madam has already said, a few drugs like at induction of anesthesia, dexamethasone, 8 milligram IV, and apart from that, even the ketamine,
Yes.
that can be used.
Or dexmedetomidine.
Yeah, alpha-2 agonist can always be added. So these two are the further drugs which can act as a preemptive.
Yes, very correct. Thanks for that addition,
Yeah,
sir.
so
Yes, we can control
It
if
is very safe to use, I suppose.
Yes.
Helps for
Yeah.
pain, helps for nausea, vomiting. Patients feel good.
Yeah, yeah.
and it gives very good post-op and intra-op results.
So Nirmal, coming to this question, now the patient is in the post-operative pain, and how would you assess those patients, and how would you tackle those situations where the pain doesn't subside for few hours after surgery as well?
To answer this, like we need to understand the physiology of what causes actually post-op pain.
Yeah.
Post-op pain is not only trauma to the tissue, but the closure of the tissue also causes a certain amount of ischemia. The retraction of the tissues during surgery, it causes damage to the muscles, damage to the nerves. It is a stretch damage to the tissues as such. So managing them with only an analgesic is not going to help. That is a basic principle. So you need to have some anti-inflammatory action as well. So basic what we have been taught, only opioids, a lot of discussion on opioids. Rather than that, I would prefer still NSAID, which has got some anti-inflammatory action, definite anti-inflammatory action, especially in a setting of post-op pain. So that has to be taken care of. And apart from that, like as far as analysis is concerned, we always, a patient who is responsive can always tell us, and we have got all these scales available with visual analytic scale or the facial expression scales are there to tell how much of pain is there. If we go on discussing this, like there is a definite concept of a multimodal analgesia.
Yes.
And as we have already discussed, a preemptive analgesia starts with counseling of the patient, preparing the patient, relieving their anxieties, then preemptive analgesias, epidurals, to intra-op, what we discussed, what medications we can give, to post-operatively where we can, infiltrate the tissues, we can have a peripheral nerve blocks, we have got various sheath blocks, for laparotomy tap blocks are always there. Then in post-op limb surgeries, we have got the perineural catheters to be inserted. And we have got a lot of options where we take deal this problem of post-op pain according to the patient's requirement, the type of surgery that the patient has undergone.
Very correct. Dr. Vyavahare, the next question is the continuation of this topic. What is multimodal analgesia?
Okay, so multimodal analgesia is a balanced analgesia where we use two or more different types of drugs with a different pharmacology and acting on different sites in the pain pathway in order to have a synergistic effect of all these drugs and to optimize the analgesia, at the same time reduce the dose and also have lesser side effects. So basically we are just combining all these drugs in order to get the best output. And in multimodal analgesia, we can use, as we have already discussed, all different drugs with different pharmacology, like paracetamol, then NSAIDs, then of course we have steroids, then you can use site-specific analgesia.
Yes, yes.
That
That's
is
a very new thing, and
Yes.
to be, yes.
Yeah, it is definitely a very interesting. And now POCUS, that is the point of care anesthesia, point of care ultrasound in regional anesthesia has revolutionized the analgesia technique. So now we are not doing all blind procedures, but we are visualizing and target specific analgesia we are giving. So
That's
that
a
is
very correct.
very good USG guided blocks. Yeah.
So site-specific blocks is very much coming in, and it's like a new thing in the management of acute pain, intra-op and post-op. My next question is to Dr. Sapre ma'am. What do you advise on menstrual pain? It seems to be very significant pain, but actually when it comes to, if you ask a patient, it is quite significant. How do you tackle with?
Yes. The aim to relieve these pains is either by affecting the physiological mechanisms behind the menstrual pain or by just relieving her symptoms. In primary dysmenorrhea, there is no pelvic pathology. She just have pain during menstruation. So in that case, we can give her simple analgesics like paracetamol, aspirin, NSAIDs if they are not contraindicated. In secondary dysmenorrhea, there is some pelvic pathology like endometriosis. In that case, we have to add some hormonal combined oral estrogen progesterone pills because that will inhibit the ovulation. And so she will, no ovulation, so no pain. that has additional benefit of providing contraception to the patients who need it. In addition, we have one more very good pain relieving modality, that is intrauterine device, which is a levonorgestrel releasing IUCD that we call. It releases a certain amount of progesterone in the, through that device. So the patient does not have to take tablets orally every day, and there is no problem of breakthrough bleeding. But the limitation is that we cannot use it in nulliparous women. So when we categorize them into primary and secondary, I think we can manage it very well.
Okay, yeah, thank you. And this is the question for Dr. Pradeep Mishra, sir. Can you briefly give this the algorithm to treat acute attacks of headaches?
You are asking for a very brief algorithm for a vast topic. Headache
Yeah, I
itself
know
is such
that.
a
Just
vast topic
what is
now.
the first line of drugs again?
So
Depending
again,
on
no, so headache is a topic wherein you have treatment based on what type of condition the patient is
I know.
suffering from. The first and foremost, I would like to exclude, again, life-threatening disorder in a patient who presents with headache. Headache, as we know, can have primary headache syndromes, which are essentially benign conditions, and you can have acute headaches, which are secondary headaches, and wherein the underlying cause can really be life-threatening. So first and foremost thing is to rule out life-threatening causes of acute headache, like subarachnoid hemorrhage, like SOLs, like meningitis, encephalitis, like cortical sinus thrombosis, like and some acute ocular conditions like acute angle glaucoma. So these are, glaucoma may not be life-threatening, but glaucoma definitely is vision-threatening condition. So first thing is to rule out these conditions, and then if you have excluded secondary headaches, then you come to primary headache syndromes, wherein essentially it is migraine, tension type headache, and cluster headache, which are very unusual. The commonest would be migraine, wherein depending on the severity of headache and depending on the presence of nausea and vomiting, you would like to, for mild patient without nausea, vomiting, you might use simple analgesics. If this is not the first attack, you can always go back to the patient, ask himself or herself, whatever has given the patient relief in the previous attacks can always be consumed. So it can be simple analgesics, non-steroidal anti-inflammatory drugs. If it is a patient has nausea, vomiting, maybe you can use parenteral agents. And migraine-specific agents like triptans can be used. Sumatriptan is one which is available for oral use and for injectable use. So at least the I have the most experience with sumatriptan. So those are the agents which can be used for acute migraine, depending on the severity. Tension type headaches generally do not require urgent intervention because by nature they are mild to moderate in nature. So simple analgesics, NSAIDs can always be used. Cluster headaches can be very severe headaches, but fortunately they are very unusual. And acute treatment of cluster headaches involves giving high flow nasal oxygen, say 15 liters per minute, by a non-rebreather mask for about 10-15 minutes, gives good response in majority of the patients. And they also can be used, triptans also can be, sumatriptan also can be used for patients with cluster headache. I do not have much experience of having seen many cluster headache patients, but then preventive therapy also has to be started simultaneously in patients with acute cluster headache because to prevent a second cluster from coming up again.
Look, I would like to add here, like sir has said, that we are giving so many things, high flow, nasal oxygen and all. But sphenopalatine block nasally that we do, it is very good to abort this.
But that
these
will require some specialty training, no?
Yeah. No, like we are managing that. That's why I said. So that is a very good.
And having said all that, the first priority is still to exclude life-threatening disorders, and in this, a careful history and physical examination. Like, is it a thunderclap headache?
I think
Is it the first and the worst headache?
Yes.
So these two things, if you ask, a thunderclap headache and the first and the worst headache will always have a secondary cause to it.
Thank you. And this is next question for Dr. Alankar. Can you briefly tell us about this fast or enhanced pain recovery protocols after surgery?
Enhanced recovery protocols after surgery is now an organized society, ERAS. It was first started by Professor Kele maybe 20, 25 years ago in Denmark. He is a gastroenterologist surgeon. So basic thought was surgery is a stressful procedure. So we try to reduce the stress of surgery as much as possible. The basic tenets would be, I think there are 3 parts, pre-op, intra-op and post-op. The basic things that we do, there are 5 or 6. Number 1, reduce the stress during surgery. Number 2, less starving. Especially in gastroenteral surgery, the surgery if done, it affects the bowel movements. And then surgery itself is a kind of a catabolic phenomenon. So less starving before surgery, after surgery. So we used to, when we were residents, we used to starve the patients for ages. Now we are not starving these patients. Clear fluids up to 2 hours before surgery and solid up to 6 hours after surgery. Even after surgery, we are not starving our patients. 2 hours after surgery, we give them clear fluids. They are okay, no vomiting. They get soft food, they start eating immediately. So bowel movement starts happening. So don't starve the patient. And then less invasive surgical techniques. When we do surgery, like Dr. Nirmal said, don't do a lot of soft tissue trauma, do focus surgery, less trauma, less retraction, all these things.
Yeah.
Less bleeding, less blood transfusion. So keep it as physiological as possible. Then very good pain control. So we have discussed preemptive analgesia, multimodal analgesia, regional anesthesia. And then immediate mobilization after surgery. So patients, once they get limb control, for example, in my books, my practice, as soon as the patient is able to do active SLR, he starts walking without a brace, of course with a walker. Early mobilization reduces complications. Then very little and judicious use of IV fluids, not bombarding them with IV fluids without need. So goal-based IV fluid therapy. Very good pain control, less blood, and then as less tubes as possible. So I think we have to use epidural because some people are doing it with blocks too, but then as little tubes as possible, the patient is free, he feels free, and early mobilization, early discharge, early recovery. Of course, this is not applicable to all patients, but then definitely for a selected group of
These
patients.
are very important points which one need to follow. At the lastly, we will have 2 quick questions.
Adductor canal
wanted to
block,
add?
adductor canal block instead of epidural if it is contraindicated in many cases. So it helps in enhanced recovery.
So let me just add a little this. So adductor canal blocks as compared to epidural, they are associated with very good pain control, but adductor canal blocks are not associated with early recovery after surgery. Especially sometimes they can have more pain and quadriceps function can be inhibited.
Yeah, it depends on the percentage. I mean, it's
Actually, it depends on the
The quick
situation.
questions for all the panelists, 2 quick questions. First is, what is your first drug of choice if a patient presenting in OPD with pain? The safe and whatever the pain it could be, musculoskeletal or any other. What is your choice of first line of drug? Mishra sir?
Ibuprofen.
Ibuprofen. Alankar?
Aceclofenac, paracetamol.
Okay.
yeah, even aceclofenac is a very good. with
Paracetamol. Nirmal, any difference?
NSAID plus paracetamol.
NSAID, which one?
Diclofenac.
Neeta?
For gynec patients, yes, but for obstetric patient, I need to be very careful.
Yeah.
If the NSAIDs I cannot give.
Say
so
one drug.
Paracetamol, tramadol.
Okay, the safest one, yeah. And the second question is the various patches are available nowadays, the fentanyl or the even keto patch, all these patches. So what is your take on those? Whether you use it, and if you use it, which patch? Neeta, do you use any patch?
Not for obstetric patients, but
Yeah.
yes, for gynecology, we can use fentanyl patches. It gives very good pain relief.
Okay, Nirmal?
Fentanyl patches, ketorolac patches sometimes.
Okay.
Yeah, fentanyl patches and buprenorphine patches are also very good.
Alankar, any differences in the patches used?
Yeah, I have used fentanyl patches rarely, but my patients, they complain of itching and also vomiting sometimes with fentanyl patches too.
Yeah. Mishra sir, you wanted to add anything?
No. I had never used fentanyl patches before, but since now I am working with NCI, we are using a lot of for cancer pain, a lot of fentanyl as well as those patches are being, a lot of opioids are being used.
Yeah.
So because of some shortage of time, we are actually ending our panel
Madam,
discussion.
just a
Yes?
very important
Okay. Yeah,
point which
sure.
I want to make is like what we usually forget and usually we very conveniently ignore is the training of the hospital staff. Just a quick share of 2 incidences where an epidural catheter It's a protocol with epidural, like laparotomies, thoracotomies, we regularly inject epidural catheters and give medicines. On 2 occasions, the sensor cane attached to the epidural catheter was connected IV, one. Second, a KCL correction advised in the post-operative period for hypokalemia, KCL was given through the epidural. So these are the conditions which I have faced, I have come across personally. So there may be many more. So these mishaps need to be very anticipated. A proper training of all the staff involved in the post-op care, that has to be done. And we as physicians and surgeons, the primary responsibility is ours.
Yes, rightly said. Education is also a very important part of acute pain service.
Yeah.
Yes, very much. Education and training of the staff, and educating and taking the training programs again and again to boost the importance of the newer techniques of management of pain. So here we come to the end of the session with a take-home message that diagnosis of the pain generator is very important. All acute pains should be treated adequately and immediately. If not, they lead to chronic pain syndrome and stress disorders. Different pains need different analgesics and co-analgesics. Procedure-specific analgesia algorithm should be followed for all major traumas and major surgeries. Use of anti-inflammatory analgesics and opioids should be judicious. We have not taken many questions on opioid tolerance, addiction and all because our time was not permitting us. Regional nerve blocks and epidurals is a safe and effective modality if everybody is trained properly. Preemptive and multimodal and non-pharmacological methods help to reduce the total dose of opioids and NSAIDs and thereby reducing the side effects. And rehabilitation is as important as the management. Thank you very much for the panelists
Thank
to
you
give
so much
the
for
time.
the opportunity. Thank you so
Thank you,
much.
audience, for listening patiently.
Yeah. Thank you, everybody.
We can have more discussion at the lunchtime.
Very interesting and informative panel discussion, wonderfully moderated. I request Dr. Ravindra Sarnaik sir, President AMS, and Dr. Nainesh Patel, Honorary Secretary AMS, to felicitate our panelist, Dr. Mishra sir. Dr. Alankar Ramteke. Dr. Kiran Vyavhare. Dr. Nirmal Padle. Dr. Neeta Sapre. And our moderators, Dr. Manoj Pahukar. Dr. Manoj Pahukar. Dr. Archana Deshpande. I request all the panelists to come for a photograph.